Welcome to the Deep Dive. Today we're focusing on a common A&E presentation, a young patient with hip pain.
Always a good one.
We'll explore the history, examination, investigations, and management of slipped upper femoral epiphysis.
SUFE.
SUFE, exactly.
A condition we must consider in any adolescent presenting with hip or knee pain. Let's dive into a case.
Okay, let's.
Imagine a 13-year-old girl brought in by her mother, worried about a potential groin strain her daughter sustained playing netball.
Sounds straightforward enough. Active young girl, sports injury. Could be a simple muscle strain, right?
That's what the mother assumes, but there are some red flags in the history that should alert us to the possibility of something more serious, like SC.
Okay, so what specific questions would you be asking to tease out those red flags?
Well, first I want to know more about the pain itself. When it started, where exactly it's located, how severe it is, and if it's impacting her daily activities.
So a really thorough pain history.
Yes.
Anything else in the history that could point towards SUFE?
Asking about referred pain is crucial. In SUFE, pain can radiate to the knee even if the primary problem is in the hip. So I'd specifically inquire about any knee pain even if the main complaint is groin pain.
So a detailed pain history, including duration and location, along with any referred pain, helps us differentiate between a simple muscle strain and something more concerning, like SUFE. What about the examination? What findings would support a diagnosis of SUFE?
A thorough gait assessment is key. Observing how the patient walks can reveal a lot.
Yeah.
Look for a limp, any external rotation of the foot, or limited hip movement.
So we're moving away from confirming a groin strain to actively searching for signs of a hip problem.
Precisely.
Yeah.
And remember, it's crucial to examine both hips even if the pain is only on one side. 20% of SUFE cases are bilateral, meaning both hips are affected.
Good point. It highlights the importance of a comprehensive assessment, not just focusing on the symptomatic side. So we've taken a thorough history, performed a detailed examination. What investigations would you order to confirm your suspicions?
X-rays are the gold standard.
X-rays, yeah.
We'd request an EP pelvis and a frog-leg lateral view of both hips. If there's any knee pain, we should also X-ray the knee.
Okay, and what exactly are we looking for in these X-rays?
The key finding in SUFE is the slippage of the femoral head epiphysis posteriorly and inferiorly in relation to the femoral neck.
Posteriorly and inferiorly.
Imagine a scoop of ice cream slipping off a cone that's similar to what happens with the femoral head in PFE. These specific X-ray views allow us to clearly visualize this displacement.
So the X-rays aren't just confirming a bony problem, they're giving us specific information about the nature of that problem.
Absolutely. Based on those X-ray findings, we can make a definitive diagnosis of slipped upper femoral epiphysis.
So let's assume the X-rays confirm our suspicions, and this young girl does indeed have SUFE. Before we move on to management, could you briefly explain what SUFE is and who it typically affects?
Certainly. SY is a condition where the ball at the top of the femur, known as the femoral head, slips out of position on the growth plate. This displacement occurs through the physis, or growth plate, which is a weaker area in the bone. It tends to affect adolescents during their growth spurt, particularly girls between 10 and 13 and boys slightly later, often between 13 and 16.
So our patient falls right into that classic age group where SV is more common.
Yes, and the X-rays have provided the definitive evidence we need to confirm the diagnosis.
Right. So we have our diagnosis.
Yeah.
Now, how do we approach the management of SE?
First and foremost, we need to reassure both the mother and child. It can be a daunting diagnosis, so clear and empathetic communication is vital.
Makes sense. A scared and confused patient is unlikely to cooperate or engage with the treatment plan.
Absolutely. Next, we need to address the pain. We'd provide appropriate analgesia to keep her comfortable. Then, depending on the severity of the slip and the stability of the joint, we might need to discuss admission for bed rest.
Essentially, taking the weight off that hip to prevent further slippage.
Precisely. Now, the definitive treatment for SUFE is surgical fixation.
Okay.
We would use a cannulated screw to fix the slipped epiphysis in place, preventing further displacement and encouraging the growth plate to fuse properly.
So surgery is typically required to address the underlying problem. What about the long-term prognosis for patients with SUFE?
Most patients do well with prompt treatment. However, there are potential complications such as a vascular necrosis disruption of the blood supply to the femoral head.
Could you elaborate on a vascular necrosis and any other potential complications we should be aware of?
Certainly, a vascular necrosis can lead to pain, deformity, and even arthritis later in life.
Right.
Another potential complication is malunion, where the bone heals in a less than ideal position, potentially leading to future joint problems.
So early diagnosis and prompt treatment are crucial to minimize those risks.
Absolutely. The earlier we intervene, the better the chances of a good outcome for the patient.
This has been incredibly helpful in understanding the key aspects of SUFE. Before we move on to discussing the different classifications of SUFE, is there anything else we need to address regarding diagnosis and initial management?
I think we've covered the essentials. We've highlighted the importance of a thorough history, a focused examination, and appropriate investigations to reach a definitive diagnosis. We've also touched upon the initial steps in management, including reassurance, pain relief, and the need for surgical intervention.
Excellent. Now let's delve a bit deeper into those classifications of SUFE as they have a significant impact on how we manage the condition.
Let's explore those SUFE classifications further. As you rightly said, they impact our management approach. We can categorize SUFE as acute versus chronic and stable versus unstable.
Okay, so what distinguishes an acute slip from a chronic one?
An acute slip usually follows a sudden trauma, such as a fall or a sports injury with immediate and severe symptoms. Conversely, a chronic slip develops gradually over time with intermittent pain.
Given our patient's 2-month history of pain alongside her recent netball game, how do we determine whether this is an acute flare-up of a chronic condition or a new acute injury?
The prolonged pain suggests an underlying chronic slip, with the netball game likely exacerbating it rather than being the primary cause.
Okay, that clarifies the acute versus chronic distinction. What about stable versus unstable? What does that classification refer to?
This classification hinges on the patient's ability to bear weight on the affected leg.
Okay,
If they can, it's considered stable. If not, it's unstable.
so an unstable slip suggests a more severe displacement of the femoral head, potentially requiring more urgent intervention.
Precisely. Unstable slips often necessitate prompt surgical intervention to prevent further displacement and potential complications.
Now, you mentioned earlier that the management approach varies depending on the classification. Could you elaborate on that?
Certainly. In acute unstable slips, the surgeon might attempt a closed reduction, manipulating the femoral head back into position before securing it with a screw.
Is that similar to relocating a dislocated shoulder?
Yes, quite similar. However, in chronic slips, attempts at reduction carry a higher risk of compromising the blood supply to the femoral head, potentially leading to a vascular necrosis.
So in chronic slips, the focus shifts to stabilizing the existing displacement to prevent further slippage and promote growth plate fusion.
Exactly. We call this in situ fixation, securing the slipped epiphysis in its current position using a cannulated screw.
Okay. That brings us back to our hypothetical patient. Assuming the x-rays confirm SUFE, what immediate steps do we take? Do we proceed directly to surgery?
Not necessarily. Our immediate priority is preventing further slippage. This usually involves advising the patient to avoid weight bearing on the affected leg, often using crutches or a wheelchair.
So strict rest and restricted activity are paramount.
Indeed. Alongside pain management, we'd engage a senior orthopedic surgeon to chart the best course of action, be it immediate surgery or a period of observation with restricted weight bearing.
That underscores the value of a multidisciplinary team approach in managing such cases.
Absolutely. Collaboration between A&E doctors, orthopedic surgeons, and physiotherapists ensures comprehensive care for the patient.
This deep dive into SUFE has been incredibly insightful. It's remarkable how a seemingly simple presentation of hip pain can unveil such complexity.
It reinforces the need for meticulous history-taking, thorough clinical examination, and appropriate investigations to unravel the true nature of the condition.
Now let's shift our focus to the surgical management of SUFE, exploring the procedure itself and the post-operative care involved. We've discussed the diagnosis and initial management of SUFE. Let's now delve into the surgical procedure itself. What does surgical fixation for SUFE entail?
The surgery is typically performed under general anesthesia. The surgeon makes a small incision over the hip and, guided by X-ray images, inserts a cannulated screw across the growth plate.
Right.
This screw secures the femoral head to the femoral neck, preventing further slippage.
You mentioned a cannulated screw. What makes this type of screw particularly suited for this procedure?
A cannulated screw has a hollow core, allowing it to be placed over a guide wire. This ensures precise placement, which is crucial in this operation.
So precision is key to avoid damaging surrounding structures and ensure optimal stabilization.
Absolutely. The screw's position is meticulously checked under X-ray to confirm stability before the incision is closed.
This sounds like a minimally invasive procedure.
Relatively, yes. The incision is small, and the surgery itself is usually straightforward.
What about post-operative care? Can the patient return to their active lifestyle immediately?
Not quite. After surgery, weight bearing on the affected leg is restricted for about 6 to 8 weeks. The patient will likely use crutches or a walker during this time.
So a period of rest and recovery is essential.
Precisely. This allows the bone to heal properly around the screw. Physiotherapy will also play a crucial role in regaining range of motion and muscle strength.
A gradual return to activity then, ensuring optimal healing and rehabilitation. What about the screw itself? Does it remain permanently?
Typically, the screw remains in place until skeletal maturity, that is, until the growth plates have fully closed.
So it acts like an internal scaffold supporting the femoral head until the bone is strong enough.
An apt analogy. Once skeletal maturity is reached, the screw can be removed if it causes discomfort or at the patient's request. However, in many cases, it's safely left in place permanently.
It's remarkable how this seemingly straightforward sports injury has unveiled a complex medical journey, encompassing anatomy, growth plates, slipped epiphyses, and even surgical screws.
Indeed, this case highlights the importance of thorough assessment, a broad differential diagnosis, and a comprehensive understanding of adolescent musculoskeletal health. Early recognition and prompt management of SUFE are crucial to optimize patient outcomes and minimize the risk of long-term complications.
This deep dive into SUFE serves as a valuable lesson for aspiring surgeons, emphasizing the need for vigilance, attention to detail, and a commitment to lifelong learning. What initially presents as a simple complaint can often harbor hidden complexities. Remember, a curious mind, a keen eye, and a dedication to ongoing education are the cornerstones of a successful surgical career. Thanks for listening.